Scott Brown's Otology, Audiovestibular Medicine, Chapter 46, Anatomy and Embryology of the External and Middle Ear. Here we are going to discuss on the middle ear cleft. The middle ear cleft. The middle ear cleft consists of the tympanic cavity, the estriation tube, and the mastoid air cell system. The tympanic cavity is an irregular air-filled space within the temporal bone between the tympanic membrane laterally and osseous labyrinth medially. It contains the auditory ossicles and the tendons that attach them to the middle ear muscles. Other structures, including the tympanic segment of the facial nerve, run along its wall to pass through the cavity. The tympanic membrane. The tympanic membrane lies at the medial end of the external auditory meatus and forms the majority of the lateral wall of the tympanic cavity. It is slightly oval in shape, being broader above than below, forming an angle of about 55 degrees with the floor of the meatus. Its longest diameter from the posterior superior to anterior inferior is 9 to 10 millimeter, while perpendicular to this is the shortest diameter is 8 to 9 millimeter. Most of the circumference is thickened to form a fibrocartilaginous ring, the tympanic annulus, which sits in a groove of the tympanic bone, the tympanic sulcus. The sulcus does not extend into the notch of Rivinus at the roof of the canal, which is formed by a part of the squama of the temporal bone. From the superior limits of the sulcus, the annulus becomes a fibrous band which runs centrally as anterior and posterior malleolar folds to the lateral process of the malleus. The handle, which is clearly visible within the tympanic membrane. This leaves a small triangular region of the tympanic membrane above the malleolar folds within the notch of Rivinus called the pars flaccida, which does not have a tympanic annulus at its margins. The pars tensa forms the rest of the tympanic membrane and is concave towards the ear canal, but each segment is slightly convex between the lateral attachment of the annulus and the center of the membrane, where the tip of the malleus handle is attached at the umbo. Figure 46.4, endoscopic photograph of the right tympanic membrane. Both the pars flaccida and pars tensa comprise three layers. There is an outer epithelial, the epidermis, which is continuous within the skin of the external meatus, a middle, mainly fibrous layer, the lamina propria. The inner mucosal layer continues with the lining of the tympanic cavity. The lamina propria of the pars tensa has radially oriented fibers in the outer layers and circular parabolic and transverse fibers in the deeper layers. This arrangement probably accounts for the complex pattern of the tympanic membrane displacement during sound stimulation. In the pars flaccida, the lamina propria is less marked and orientation of the collagen fibers seems random. The arterial supply of the tympanic membrane arises from the branches supplying both the external auditory meatus and the middle ear. These two sources interconnect through extensive anastomosis within the connective tissue layer of the lamina propria. The epidermal vessels originate from the deep auricular branch of the maxillary artery coming from the external auditory meatus, whereas the mucosal vessels arise from the anterior tympanic branch of the maxillary artery, the stylomastoid branch of the posterior auricular artery, and probably from the middle meningeal artery. Branches of the auricular temporal nerve, 5C, the auricular branch of the vagus, and the tympanic branch of the glossopharyngeal nerve supply the tympanic membrane. These also run in the lamina propria, and while the variations and overlap are considerable, both the vascular supply and innervation are relatively sparse in the middle part of the posterior half of the tympanic membrane. The tympanic cavity. The tympanic cavity is traditionally divided into three compartments: the epitympanum upper, the mesotympanum middle, and the hypotympanum lower. The epitympanum or the attic lies above the level of the malleolar folds and is separated from the mesotympanum and hypotympanum by a series of mucosal membranes and folds. The hypotympanum lies below the level of the inferior part of the tympanic sulcus and is continuous with the mesotympanum above. With the advent of endoscopic ear surgery, the mesotympanum may be considered as a part of the middle ear visible through the external canal with a microscope. The retrotympanum lies posterior to it and includes both the posterior medial and posterior walls of the tympanic cavity, whereas the protympanum is anterior to the promontory and is contiguous with the tympanic portion of the eustachian tube. The lateral wall. The lateral wall of the tympanic cavity is formed by the bony lateral wall of the epitympanum superiorly, the tympanic membrane centrally, and the bony lateral wall of the hypotympanum inferiorly. The lateral epitympanum wall is wedge shaped in the section, and its sharp inferior portion is also called the outer attic wall or scutum. Latin shield. It is thin and easily eroded by cholesteatoma, leaving a telltale sign or high resolution coronal CT scan. Three holes are present in the bone of the medial surface of the lateral wall of the tympanic cavity. The petrotympanic fissure is a slit about 2 millimeter long, which opens anteriorly just above the attachment of the tympanic membrane. It receives the anterior malleolar ligament and transmits the anterior tympanic branch of the maxillary artery to the tympanic cavity. The chorda tympani, which carries taste sensation from the anterior two-thirds of the same side of the tongue and secretomotor fibers to the submandibular gland, enters the medial surface of the fissure through a separate anterior canaliculus, the canal of Hugger, which is sometimes confluent with the fissure. It then runs posteriorly between the fibrous and mucosal layers of the tympanic membrane, across the upper part of the handle of malleus, and then continues within the membrane but below the level of the posterior malleolar fold. The nerve reaches the posterior bony wall just medial to the tympanic sulcus, enters the posterior canaliculus, and then runs obliquely downwards and medial through the posterior wall of the tympanic cavity until it reaches the facial nerve. The point of entry of the chorda tympani into the facial nerve bundle is quite variable. Usually, this is at the level of the inferior third of the facial canal on its anterior wall, but on occasions, the chorda can leave the skull base by a separate foramen before it joins the facial nerve. During cortical mastoidectomy, the fibrous strands of the tympanomastoid suture line often be confused with chorda tympani, although the angle of the white strands of the suture line is different from the angle of the chorda. Figure 46.5, the tympanic membrane viewed from the middle ear. The chorda tympani runs superior to the tinsa tympani in its passage across the tympanic membrane and lies medial to the anterior malleolar ligament in the anterior attic. The adductus to the mastoid antrum A lies posterior superior to the short process of incus I. Tensor tympani, chorda tympani, incus, mastoid antrum. Figure 46.6, a specimen cut axially at the level of the labyrinth and intratympanic segments of the facial nerve 7, showing a small cholesteatoma C lying between the head of the malleus and the anterior epitympanic space. The oscular heads resemble a spoon scoop of ice cream in a cone, which can be readily seen on high resolution axial CT. I incus M malleus. Incus malleus cholesteatoma and facial nerve. The roof. The roof of the epitympanum is the tegment tympani, a thin bony plate that separates the middle ear space from the middle cranial fossa. Both the petrous and squamous portions of the temporal bone form it, and the petrosquamous suture line, which does not close until adult life, can provide a route of access for infection into the extradural space in children. Veins from the tympanic cavity run to the superior petrosal sinus, pass through the suture line. There is a bony crest known as cog, which projects from the mid tympani caudally to lie anterior to the head of the malleus and can be of variable size. This structure divides the larger posterior epitympanic space from the smaller anterior epitympanic space, where residual cholesteatoma may be left if not formally explored in canal wall upsurgery. The floor. The floor of the tympanic cavity may consist of compact or pneumatized bone with spines and trabeculae. It separates the hypotympanum from the dome of the jugular bulb, and its thickness can vary according to the size height of the jugular fossa. Occasionally, the floor is deficient and the jugular bulb is then covered only by a fibrous tissue and a mucous membrane. Should be kept in mind when raising the inferior portion of the tympanomeatal flap. At the junction of the floor and the medial wall of the cavity, there is a small opening, the inferior tympanic canaliculus, that allows the entry of the tympanic branch of the glossopharyngeal nerve or the Jacobson's nerve into the middle ear from its origin below the base of the skull. This also carries preganglionic parasympathetic fibers from the inferior salivary nucleus on their course to the otic ganglion. The anterior wall. The anterior wall of the tympanic cavity is rather narrow as the medial and lateral walls converge. The lower third of the anterior wall consists of a plate of bone covering the carotid artery as it enters the skull and before it turns anteriorly. This plate, which can be wafer thin or up to 3 millimeter thick, is perforated by a superior and inferior keratico tympanic nerves carrying sympathetic fibers to the tympanic plexus and by tympanic branches of the internal carotid artery. In around 2% of cases, the bone is dehiscent so that the artery is exposed in the protympanum. The middle third of the anterior wall comprises the tympanic orifice of the eustachian tube, which can be irregular, rectangular, or triangular in shape and average 5 into 4 millimeter in diameter. Just above this is a canal containing the tensor tympani muscle that subsequently runs along the medial wall of the tympanic cavity, enclosing a thin bony sheath. The upper third is usually pneumatized and may house the supratubal recess, a small niche that can be separated from the anterior epitympanic space by tensor fold. The medial wall. The medial wall separates the tympanic cavity from the internal ear. The promontory is a rounded elevation occupying much of the central portion of the middle medial wall. It covers part of the basal coil of the cochlea and usually has small grooves on its surface containing the nerves which form the tympanic plexus. Sometimes the groove contains the tympanic branch of the glossopharyngeal nerve may be covered by bone, thereby forming a small canal. The promontory gently inclines forwards to merge the anterior with the anterior wall of the tympanic cavity in the protympanum, but is more steeply sloped posteriorly. Behind and above the promontory is the oval window. This is a nearly kidney shaped opening that connects the tympanic cavity with the vestibule, but which in life is closed by the foot plate of stapes and its surrounding annular ligament. Its size naturally varies with the size of the foot plate, but on average it is 3.25 millimeter long and 1.75 millimeter wide. The oval window lies at the bottom of the depression or niche, that can be of varying width depending on the position of the facial nerve superiorly and the prominence of the promontory inferiorly. The round window niche lies below and a little behind the oval window niche, from which it is separated by a posterior extension of the promontory, forming a bony ridge called the subiculum. Another ridge of bone, the ponticulus, leaves the promontory above the subiculum and runs to the pyramid on the posterior wall of the cavity. Occasionally, this structure can resemble a bridge with a medial communication between the sinus tympani and posterior sinus, a space lying behind the posterior crust of the stapes. The round window niche is most important, commonly triangular in shape, with anterior, posterior superior, and posterior inferior walls. The latter two meet posteriorly and lead to the sinus tympani. The round window membrane is usually out of sight, obscured by the overhanging edge of the promontory, forming the niche and mucosal folds within it. The membrane is roughly oval in shape, about 2.3 into 1.9 millimeter in dimension, and lies in a plane at right angles to the plane of the stapes footplate. It tends to curve towards the scala tympani of the basal coil of the cochlea, so that it is concave when viewed from the middle ear, and it appears to be divided into the anterior and posterior portion of the transverse thickening. A further ridge of bone inferiorly running between the basal helix of the cochlea and the bone over the jugular bulb can be used as convenient landmark to separate the retrotympanum from the hypotympanum. Although first identified by Proctor, this has been renamed by Marconi et al. As the funiculus, Latin borderline. The facial nerve canal or fallopian canal runs above the promontory and oval window in an anterior posterior direction. It has a smooth rounded lateral surface that often has microdehiscences, and when the bone is thin or the nerve is exposed by the disease, there are two or three straight blood vessels clearly visible along this line of nerve. There are only straight blood vessels in the middle and ear and indicate quite clearly that the facial nerve is very close by. The facial nerve canal is marked anteriorly by the processus cochleoformis, a curved post projection of the bone, concave anteriorly, which houses the tendon of the tensor tympani muscle as it turns laterally to the handle of the malleus. Behind the oval window, the facial canal starts to turn inferiorly as it begins its dehiscence in the posterior wall of the tympanic cavity. The region above the level of the facial canal forms the medial wall of the epitympanum. The dome of the lateral semicircular canal is the major feature of the posterior portion of the epitympanum, lying posterior and extending a little lateral to the facial canal. During a cortical mastectomy, the triangular relationship of the lateral semicircular canal, the process of the incus, and the seventh nerve is often quite helpful. In well aerated mastoid bones, the labyrinthine bone over the superior semicircular canal may be prominent, running at right angles to the lateral canal and joining it anteriorly at a swelling which houses the ampullae of the two canals. In front and a little below this, above the processus cochleaformis, may be a slight swelling corresponding to the geniculate ganglion, with the bone canal of the greater superficial petrosal nerve running for a short distance anteriorly. Figure 46.7, the medial wall of the mesotympanum seen after removal of the tympanic membrane. The tympanic branch of the glossopharyngeal nerve 9 can be seen crossing the promontory. Note the notch of Revius in the roof of the canal. Figure 46.8. Endoscopic view of the retrotympanum showing the relationship between the oval window niche OWN, round window niche RWN, promontory P, facial nerve 7, and facial recess FR. The sinus tympani ST lies medial to the facial nerve between the ponticulus PONT and subiculum SUB is the sinus tympani. The region above the level of the facial canal forms the medial wall of the epitympanum. The dome of the lateral semicircular canal is a major feature of the posterior wall of the epitympanum, lying posterior and extending a little lateral to the facial canal. During a cortical mastectomy, the triangular relationship of the lateral semicircular canal, the short process of incus, and the seventh nerve is often quite helpful. In a well aerated mastoid bone, the labyrinthine bone over the superior semicircular canal may be prominent, running at right angles to the lateral canal and joining it anteriorly at a swelling which houses the ampullae of the two canals in front and a little below this. Above the post processus cochleaformis may be a slight swelling corresponding to the geniculate ganglion with the bony canal of greater superficial petrosal nerve running for a short distance anteriorly. The posterior wall. The posterior wall is wider above that below and has in its upper part a large irregular opening, the adductus and antrum, that leads back from the posterior epitympanum into the mastoid antrum. Below the adductus is a small depression, fossa incudis, which houses the short process of incus and its suspensory ligament. Below the fossa incudis and the medial to the opening of the chorda tympani nerve is the pyramid, a small hollow conical projection with its apex pointing anteriorly. This houses the stapedius muscle and tendon, which inserts into the posterior aspect of the head of stapes. The canal within the pyramid curves downwards and backwards to join the descending portion of the facial canal, nerve canal. The facial recess is a groove which lies between the pyramid and facial nerve and the annulus of the tympanic membrane. This is shallower, lower down, where the facial nerve canal forms only a slight prominence on the posterior wall. Facial recess is therefore bounded medially by the facial nerve and laterally by the tympanic annulus, with the chorda tympani nerve running obliquely through the wall between the two. The chorda always runs medial to the tympanic membrane, which means the angle between the facial nerve and the chorda allows a posterior tympanotomy to be cut, thereby accessing the middle ear from the mastoid without disrupting to the middle tympanic membrane. This angle can be smaller or larger depending on the site of the chorda from the facial nerve. The sinus tympani is a posterior extension of the mesotympanum into the posterior wall and lies deep to the facial nerve, pyramid, and stapedius muscle. It varies in size and, when extensive, is probably one of the most inaccessible sites in the middle ear when operating with the microscope. A surgical view can be enhanced using a 45-degree endoscope introduced from the opposite side of the ear being observed. The medial wall of the sinus tympani becomes continuous with the posterior portion of the medial wall of the tympanic cavity in the retrotympanum, and it is bounded superiorly by the ponticulus and inferiorly by the subiculum. Its importance is that cholesteatoma, which has extended here from the mesotympanum, is extremely difficult to eradicate, as the sinus can be extend as far as 9 millimeter into the mastoid bone when measured from the tip of the pyramid. A retrofacial dissection inferior to the posterior semicircular canal may be required should the disease be out of reach using a transcanal endoscopic approach. The relationship of the middle ear space are shown in diagrammatically in figure 46.13. Figure 46.9, a specimen cut to show the medial wall of the tympanic cavity. The processus cochleaformis PC marks the anterior portion of the intratympanic portion of the facial nerve which passes between the lateral semicircular canal LSCC and the oval window niche OWN. Note the jugular bulb JB in the floor of the tympanic cavity. Figure 46.10, a specimen cut coronally at the level of the long process of incus. The adductus to the mastoid antrum lies posterior superiorly to the incus. I. Lateral semicircular canal LSCC. Malleus M. Stapes S. And 7. Facial nerve. Figure 46.11a, the facial recess and the sinus tympani at different levels of the middle ear. Section AA is at the level of the pyramid where the facial recess is relatively deep. In section BB, at the level of the round window, the facial recess is quite shallow. The extent of the sinus tympani, deep and posterior to the facial nerve, is variable. Facial recess, seventh nerve, sinus tympani. Section AA. Facial recess, seventh nerve, sinus tympani, round window, niche. A, A, B, B, seventh nerve. B, a specimen in section AA at the level of the pyramid. B, S stapes, seventh facial nerve. FR, facial recess, and ST, sinus tympani. Seventh nerve, facial recess, pyramid, sinus tympani, stapes. Figure 46.12, posterior tympanotomy in a left ear, showing the relationship of the facial nerve 7, chorda tympani CT, annulus A, and lateral semicircular canal. The promontory is readily accessible via this approach in cochlear implant surgery. Figure 46.13, the relationship of the right middle ear. Superiorly, middle cranial fossa, temporal bone. Anteriorly, tensor tympani muscle, tube, eustachian tube. Laterally, the external auditory meatus. Inferiorly, jugular bulb, carotid artery. Posteriorly, mastoid, adductus to mastoid. Medially, internal ear. Figure 46.14, stapes, incus, and malleus with scale. The contents of the tympanic cavity. The tympanic cavity contains the ossicles, two muscles, the chorda tympani and the tympanic plexus. The ossicles are the malleus, incus, and stapes that form a semi-ridged bony canal chain for conducting sound. They can be seen photographed with a scale in figure 46.14. The malleus is the most lateral and is attached to the tympanic membrane, whereas the stapes is attached to the oval window. The malleus. The malleus is the largest of the three ossicles, measuring up to 9 mm in length. It comprises a head, neck, and handle or manubrium. The head lies in the epitympanum and is suspended by the superior ligament, which runs upwards to the tegmen tympani. The head of the malleus has a saddle shaped facet on its posterior medial surface to articulate with the body of the incus by way of a synovial joint. Below the neck of the malleus, the bone broadens and gives rise to the lateral process, the anterior process, and the handle. The lateral process is a prominent landmark on the tympanic membrane and receives the anterior and posterior malleolar folds from the tympanic annulus. The chorda tympani crosses the upper part of the malleus handle on its medial surface above the insertion of the tendon of tensor tympani, but below the neck of the malleus itself. The neck of the malleus connects the handle with the head, and the amputation of the head by cutting through the neck leaves both the chorda tympani and tensor tympani intact. A slender anterior ligament arises from the anterior process to insert into the protympanum fissure. The handle runs downwards, medially, and slightly down backwards between the mucosal and fibrous layers of the tympanic membrane. While it is very closely attached to the membrane, at its lower end there is a fine web of mucosal separating the membrane from the handle in the upper portion before it becomes adherent again at the lateral process. This can be opened surgically to create a slit without perforating the membrane to allow a prosthesis to be crippled around the malleus handle in certain types of ossicular reconstruction. On the deep medial surface of the handle, near its upper end, is a small projection into the which the tendon of the tensor tympani muscle inserts. The incus. The incus articulates with the malleus and has a body and two processes. The body lies in the epitympanum and has a cartilage covered facet corresponding to that on the malleus. The body of the incus is suspended by the superior incudal ligament that attached to the tegmen tympani. The short process projects backwards from the body to lie in the fossa inquidus, to which it is attached by a short suspensory ligament. The long process descends into the mesotympanum behind and medial to the handle of malleus, and at its tip it is a small medially directed lenticular process. This has sometimes been called the fourth ossicle because of its incomplete fusion with the tip of the long process, thereby giving the appearance of a separate bone or at least a sesamoid bone. The lenticular process articulates with the head of stapes. The stapes. The stapes is shaped like a stirrup and consists of a head, neck, and anterior and posterior crura and a full foot plate. The head points laterally and has a small cartilage covered depression for a synovial articulation with the lenticular process of the incus. The stapes tendon inserts into the posterior part of the neck and upper portion of the posterior crus. The two crura arise from the broader lower part of the neck, and the anterior crus is thinner and less curved than the posterior one. Both are hollowed out on the concave surfaces, which gives an optimum combination of strength and lightness. The crura join the foot plate, which usually has a convex superior margin and almost straight inferior margin and curved anterior and posterior ends. The average dimensions of the foot plate are 3 millimeter long and 1.4 millimeter wide, and it lies in the oval window where it is attached to the bony margins of the annular ligament. The long axis of the foot plate is almost horizontal, with the posterior end being slightly lower than the anterior. There is a great variation in the shape of the two crura. The stapedius muscle. The stapedius arises from the walls of the conical cavity within the pyramid and from the downward curved continuation of this canal in front of the descending portion of the facial nerve. A slender tendon emerges from the apex of the pyramid and inserts into the stapes. The muscle is supplied by a small branch of the facial nerve. The tensor tympani muscle. This is a long, slender muscle arising from the walls of the bony canal lying above the eustachian tube. Parts of the muscle also arise from the cartilaginous portion of the eustachian tube and the greater wing of the sphenoid. From its origin, the muscle passes backwards into the tympanic cavity where it lies on the medial wall, a little below the level of the facial nerve. The bony covering of the canal is often deficient in its tympanic segment, where the muscle is replaced by a slender tendon. This enters the processus cochleiformis, where it is held down by a transverse tendon as it runs through a right angle to pass laterally and inserts into the medial aspect of the upper end of the malleus head. The muscle is supplied by from the mandibular nerve by the way of a branch from the medial pterygoid nerve, the cauda tympani. This branch of the facial nerve enters the tympanic cavity from the posterior canaliculus at the junction of the lateral and posterior walls. It runs across the medial surface of the tympanic membrane between the mucosal and fibrous layer and passes medial to the upper portion of the handle of malleus above the tendon of tensor tympani to continue forwards and leave by the way of the anterior canaliculus, which subsequently joins the petrotympanic fissure. The tympanic plexus. The tympanic plexus is formed by the tympanic branch of the glossopharyngeal nerve, Jacobson's nerve, and by keratico-tympanic nerves, which arise from the sympathetic plexus around the internal carotid artery. The nerves form a plexus on the promontory and provide the branches to the mucous membrane lining the tympanic cavity, eustachian tube, and mastoid antrum and air cells. The plexus also provides branches to join the greater superficial petrosal nerve and the lesser superficial petrosal nerve that connects all the parasympathetic fibers of the glossopharyngeal nerve. The mucosa of the tympanic membrane. The middle ear mucosa is essential mucus secreting respiratory mucosa bearing cilia on its surface. The extent of the mucociliary epithelium varies in normal middle ears, being more widespread in the young. Three distinct mucociliary pathways can be identified: epitympanic, promontorial, and hypotympanic, the latter being the largest. Each of these pathways coalesces at the tympanic orifice of the eustachian tube. The mucous membranes lines the bony walls of the tympanic cavity and it extends to cover the ossicles and their supporting ligaments in much the same way as the peritoneum covers the viscera in the abdomen. The mucosal folds also cover the tendons of the two middle ear muscles and carry the blood supply to and from the contents of the tympanic cavity. These folds separate the middle ear space into compartments. As a result, the only route for ventilation of the epitympanic space from the mesotympanum is via two small openings between various mucosal folds, the anterior and posterior isthmus tympani. Likewise, the Prusak space is found between the pars flaccida and the neck of malleus, bounded by the lateral malleolar fold. This space can play an important role in the retention of keratin and subsequent development of cholesteatoma. The mucosal folds have been described in detail by Proctor and is depicted in figure 46.15. The blood supply of the tympanic cavity. Arteries supplying the walls and contents of the tympanic cavity arise from both the internal and external carotid system. The overlap between the branches is extensive and there is a variability in the supply between the individuals. Outline figure 46.2 outlines the general distribution of the arterial supply through the anterior tympanic and stylomastoid arteries are the biggest. The eustachian tube. The eustachian tube is a dynamic channel that links the middle ear with the nasopharynx. In adults, it is about 36 millimeter in length, a size that is normally reached by the age of 7 years. It runs downwards from the middle ear at 45 degree and is turned forwards and medially. The tube can be considered to consist of two unequal cones connected at their apices. The lateral third is bony and arises from the anterior wall of the tympanic cavity. This joins a medial cartilaginous part which makes up two-thirds of the tubal length. Just after its narrowest portion, called the isthmus, the tube is lined with respiratory mucosa containing goblet cells and mucous glands, having a carpet of ciliated epithelium on its floor. At its nasopharyngeal end, the mucosa is truly respiratory. However, in passing along the tube towards the middle ear, the number of the goblet cells and the glands decreases and the ciliary carpet becomes less profuse. The bony portion is about 12 millimeter long and is widest at its oval shaped orifice in the anterior wall of the tympanic cavity. It runs through the squamous and petrous portions of the temporal bone, gradually tapering to its isthmus where the diameter is only 0.5 millimeter or less. A thin plate of bone forms the roof, separating the tube from the tensor tympani muscle above. The carotid canal lies medially and can impinge on the bony eustachian tube. In cross section, the tube is triangular or rectangular, with the horizontal diameter being greater. The cartilaginous part of the tube is about 24 millimeter long and consists of a fibrocartilaginous skeleton to which are attached the peritubal muscles. At its upper border, the cartilage is bent over to resemble an inverted J, thereby forming a longer medial cartilaginous lamina and a shorter lateral cartilaginous lamina. The cartilage is fixed to the base of the skull in a groove between the petrous part of the temporal bone and the greater wing of the sphenoid, which terminates near the root of the medial pterygoid plate. Thus, the back posterior medial wall is composed of cartilage and the front anterior lateral wall comprises the cartilage and fibrous tissue. The apex of the cartilage is attached to the isthmus of the bony portion, while the wider medial end protrudes into the nasopharynx, lying directly under the mucosa to form the torus tuberous. In the nasopharynx, the tube opens 1 to 1.25 centimeter behind. and a little below the posterior end of the interior turbinate. The opening is almost triangular in shape and is surrounded above and behind by the torus. The salpingopharyngeal fold stretches from the lower part of the torus downwards to the wall of the pharynx. The levator palati, as it enters the soft palate, results in a small swelling immediately below the opening of the tube. Behind the torus is the pharyngeal recess or fossa of Rosenmuller. Lymphoid tissue is present around the tubal orifice and in the fossa of Rosenmuller and may be prominent in childhood. Figure 46.15, the compartments and the folds of the middle ear. A. The attic folds. Figure A. Tensor tympani fold, superior malleolar segment, tensor tympani muscle, isthmus tympani anticus, superior incudal fold, stapedius tendon, plica stapedius, pyramid, medial incudal fold, isthmus tympani posticus, posterior inguinal ligament, lateral inguinal fold, superior malleolar fold, anterior fold of von Trollsch, anterior malleolar fold, anterior malleolar ligament. Figure B, posterior superior and lateral view of the right middle ear. Superior inguinal fold, lateral inguinal fold, medial inguinal fold, stapes, intraossicular fold, handle of malleus, posterior malleolar fold, posterior fold of von Trollsch's, posterior pouch of von Trollsch's, lateral malleolar fold, Prosac space. C. The anterior pouch of von Trollsch's, viewed from the anterior aspect. Superior ligament of malleus, lateral malleolar fold, Prosac space, processus gracilis of malleus, anterior malleolar fold, anterior pouch of von Trosch's, tympanic membrane, chorda tympani, superior ligament of malleus. D. The posterior pouch of von Trosch's, viewed from a posterior aspect. Malleus, tensor tympani tendon, processus cochleaformis, chorda tympani, malleus, tympanic membrane, posterior malleolar fold, posterior pouch of von Trosch's, lateral malleolar fold, superior ligament of malleus. E. Prosac space, showing the posterior two-thirds of the space seen from front after proctor. Lateral malleolar fold, pars flaccida, anterior malleolar fold, processus gracialis of malleus, chorda tympani, tensor tympani fold, tensor tympani muscle, and superior malleolar fold. This is the malleus. Blood supply to the middle ear, branch, parent artery, region supplied. Branch, anterior tympanic branch, maxillary artery, tympanic membrane, malleus and incus, anterior part of tympanic cavity. Stylomastoid branch, posterior auricular artery, posterior part of the tympanic cavity, stapedius muscle. Mastoid branch, stylomastoid artery, mastoid air cells, Petrosal branch, middle meningeal artery, roof of mastoid, roof of epitympanum, superior tympanic, middle meningeal artery, malleus incus, tensor tympani, inferior tympanic, arterial pharyngeal artery, ascending pharyngeal artery, mesotympanum, branch from artery of pterygoid canal, meso and hypotympanum, tympanic arches, internal carotid artery, meso and hypotympanum. Figure 46.16, photo micrograph of the left eustachian tube in axial section showing its bony BET and cartilaginous CET portions. The tympanic membrane TM is retracted towards the eustachian orifice, and note the adjacent portion of the internal carotid artery ICA. Muscles attach to the eustachian tube. The tensor palati muscles arise from the bony wall of the scaphoid and form from along the whole length of the lateral cartilaginous lamina that forms the upper portion of the front wall of the cartilaginous tube. From these broad origins of the muscle descends, converges to a short tendon that runs medially around the pterygoid hamulus and then spreads out within the soft palate to meet fibers from the outer side of the midline raphe. The tensor palati separates the tube from the aortic ganglion, the mandibular nerve, and its branches, the chorda tympani nerve, and the middle meningeal artery. It is supplied by the mandibular nerve. The salpingopharyngeus is a slender muscle attached to the inferior part of the cartilage of the tube near its pharyngeal opening, and it descends to blend with the palatopharyngeus. The levator palati contains a few fibers that arise from the lower surface of the cartilaginous tube and originates from the lower surface of the petrous bone just in front of the opening for the entrance of the carotid, and from fascia forming the upper part of the carotid sheath. It first lies inferior to the tube, then crosses to the medial side and spreads out into the soft palate. Both the salpingopharyngeus and the levator palati are supplied from the pharyngeal plexus. The ascending pharyngeal and middle meningeal artery supply the eustachian tube. The veins drain into the pharyngeal plexus, and the lymphatic passes into the retropharyngeal nodes. The nerve supplies arise from the pharyngeal branch of the sphenopalatine ganglion. 5b for ostium, the nervus spinosum. 5c for the cartilaginous portion and the tympanic plexus. 9 for the bony part. Figure 46.17, schematic view of the right eustachian tube. Redraw from Sade and AR. Pharyngeal medial, tensor palati muscle, glands, levator palati muscle, Osman's fat pad, cartilage, tensor tympani muscle, mesotympanic lateral. The mastoid air cell system. The mastoid antrum is an air filled sinus within the petrous part of the temporal bone. It communicates with the middle ear by way of the adductus and has mastoid air cells arising from its walls. The antrum, but not the air cells, is well developed at its birth and by adult life has a volume of 2 ml. The roof of the mastoid antrum and the middle mastoid air cell space form the floor of the middle cranial fossa, while the medial wall relates to the posterior semicircular canal, more deeply and inferiorly to the dura of the posterior cranial fossa and endolymphatic sac. The latter emerges through the operculum of on the posterior surface of the petrous bone and derives from the endolymphatic duct, which passes through the vestibular aqueduct. Posterior to the endolymphatic system is the sigmoid sinus, which curves downwards only to turn sharply upwards to pass medial to the facial nerve and then becomes the dome of the jugular bulb in the middle ear space. The posterior belly of the digastric muscle forms a groove in the base of the mastoid bone. The corresponding ridge inside the mastoid lies lateral only not only to the sigmoid sinus but also to the facial nerve and is a useful landmark for finding the nerve itself. The periosteum of the digastric groove on the undersurface of the mastoid bone continues anteriorly and part of it becomes the endosteum of the stylomastoid foramen and subsequently the facial nerve canal. The outer wall of the mastoid lies just below the skin and is easily palpable behind the pinna. McKeown's triangle is a direct lateral relation to the mastoid antrum and is formed by a posterior prolongation of the line of the zygomatic arch and a tangent to it that passes through the posterior border of the external auditory meatus. The relationship of the mastoid antrum are shown in figure 46.18. In most of the population, the mastoid air cell system is fairly extensive with the air cells extending into the mastoid tip. The retrofacial region, the sinodural angle, and anteriorly the petrous apex and the arch of zygoma. Alternatively, the mastoid antrum may be the only air-filled space in the mastoid process when the name acellular or sclerotic is applied. This condition occurs in perhaps 20% of adult temporal bones and is seen in individuals with chronic ear disease. In normal ears, the lining of the mastoid is flattened, non ciliated epithelium without goblet cells or mucous glands. The petrous apex lies at the most medial aspect of the temporal bone and is shaped like a foreshortened pyramid pointing anteriorly and medially. The posterior medial surface of the petrous apex is the part of the posterior cranial fossa, while the superior aspect of the bone forms the floor of the middle cranial fossa. The internal carotid artery and the internal auditory meatus runs through the bony petrous apex. At the apex of the petrous bone is the trigeminal nerve running into the Meckel's cave with the abductor nerve passing close to its roof. Gradingo syndrome is a result of infection at the petrous apex and comprises a lateral rectus palsy, facial pain, and discharging ear. Historically, the petrous apex has been the most difficult to access surgically, but this has been advanced by the development of the endoscopically assisted transsphenoidal techniques. Relationship of the right mastoid antrum: superiorly the middle cranial fossa, medially the posterior cranial fossa, posteriorly the sigmoid sinus, inferiorly jugular bulb, digastric muscle, and sternomastoid muscle, laterally the postauricular skin, anteriorly the middle ear, external auditory meatus, and facial nerve. Figure 46.19, endoscopic view of the apex of the lateral left internal auditory meatus. Superior vestibular nerve region, Bill's bar superiorly, facial nerve region, transverse crest, anteriorly cochlear nerve region, inferior vestibular nerve region, sigmoid, singular foramen, posterior. The internal auditory meatus. This is a short canal nearly 1 centimeter in length and lined with dura which pass into the petrous bone in lateral direction from the cerebellopontine angle. It transmits facial, cochlear, and vestibular nerves and the internal auditory artery and vein. The meatus is closed at its lateral end and or the fundus by a plate of bone that is perforated for the passage of nerves and blood vessels to and from the cranial cavity. The bony plate separating the fundus from the middle and internal ears has a lateral transverse crest, the crista fasciformis, on its inner medial surface, which separates a small upper region from a large lower region. Above the crest and anteriorly is the opening of the facial canal carrying the facial nerve 7. This is separated by a small vertical ridge known as the Bill's bar from the posterior region that transmits the superior vestibular nerve through several small foramina to the superior and lateral semicircular canals, to the utricle and a part of the saccule. Below the transverse crest, the nerve lies anteriorly and leaves the meatus through the cochlear area, which comprises a spiral of the small foramina and a central canal. The inferior vestibular nerve passes through one or two foramina behind the cochlear opening to supply the saccule. Just behind and below the inferior vestibular foramen is the foramen cingulare, which contains the singular nerve. This runs obliquely through the petrous bone close to the round window to supply the sensory epithelium of in the ampulla of the posterior semicircular canal. This is the diagram. Thank you.